Bismillahirrahmanirrahim. وَقُولُوا لِلنَّاسِ حُسْنًا and speak nicely to people. So today we will discuss renal calculi or stones and the chemical analysis of renal calculi. So renal calculi, also known as nephrolithiasis or urolithiasis, is a condition in which a solid piece of material develops in the urinary tract. This solid material, that is called a stone, may pass in the urine if it is small, but if it is more than 5 millimeter in diameter, it can cause blockage and result in different symptoms like sharp and severe pain in the lower back or abdomen. A stone may also result in blood and urine, that is hematuria, vomiting, and painful urination. Kidney stone may form by a combination of genetic and environmental factors, but these are some of the risk factors which include dehydration, high urine calcium levels, calcium supplements, hyperthyroidism, and gout. The diagnosis of the nephrolithiasis is based on symptoms, urine testing, and medical imaging like KUB, CT scan, intravenous speleogram, and blood tests are also useful in the diagnosis. Renal stones can be classified on the basis of their location in the urinary tract and on the basis of their chemical compositions. So based on their location, if the stone is present in the kidney, this is known as the nephrolithiasis. If it is present in the ureter, this is known as urolithiasis. And if it is present in the bladder, it is known as cystolithiasis. So based on the chemical composition, we may have different types of the renal stones that may be made of the calcium oxalate, so it is known as the calcium oxalate stone. It may be made up of the uric acid, so it is known as the uric acid stone, or steroid and cystine respectively. There are different sizes of the stones. So those stones which are less than 5 millimeter in diameter pass spontaneously in the urine in up to 98% of cases. But those stones whose diameter is 5 to 10 millimeter pass spontaneously in less than 53% of cases. Stones that are large enough to fill out the renal calyces are called staghorn stones and are composed of steroid in a vast majority of cases, which form only in the presence of urease forming bacteria. Other forms that can possibly grow to become staghorn stones are those composed of cystine, calcium oxalate monohydrate, and uric acid. The pathophysiology of renal stone is when the urine becomes supersaturated with one or more calculigenic substances. It leads to the crystal formation by the process of nucleation. So heterogeneous nucleation, where there is a solid surface present on which a crystal can grow, proceed more rapidly than homogeneous nucleation, where a crystal must grow in liquid medium with no such surface because it requires less energy. Adhering to cell on the surface of renal papilla and seed crystal can grow and aggregate into an organized mass. Depending on the chemical composition of the crystal, the stone forming process may proceed more rapidly when the pH is unusually high or low. It is very important to note that supersaturation alone is not sufficient for the formation of renal stone. But in case of calculogenic compounds, the pH also plays an important role. For example, at a pH of 7, the solubility of uric acid is 158 mg per deciliter. Reducing pH to 5 decreases the solubility of uric acid less than 8 mg per 100 deciliter. So the formation of uric acid stone requires a combination of both hyperuricosuriia, that is the supersaturation, and low urine pH. Hyperuricosuriia alone is not associated with uric acid stone formation if the pH is alkaline. Similarly, supersaturation of the urine is a necessary but not sufficient condition for the development of urinary calculus. Supersaturation is likely the underlying cause of uric acid and cystine stone, but calcium-based stone, especially calcium oxalate stones, may have more complex causes. This table represents different types of the renal stones, their frequency in the population, the circumstances in which these stones develop, and their physical and chemical characteristics. So as the table indicates, calcium oxalate is the most frequent, and the circumstances in which a calcium oxalate stone is formed is when the urine is acidic. The color of this stone is black or dark brown, and it is radio opaque. Similarly, calcium phosphate, uric acid, and steroid, these are also frequent in the population as compared to the cystine and xanthine. There are some other types of the renal stones, like people with certain rare inborn errors of metabolism, especially in the amino acid metabolism, have a propensity to accumulate crystal forming substances in their urine. For example, those with cystinuria, cystinosis, and Fanconi syndrome may form stones composed of cystine. Cystine stone formation can be treated with urine alkalinization and dietary protein restriction. People afflicted with xanthinuria often produce stone composed of xanthine. Similarly, people afflicted with adenine phosphoribosyl transferase deficiency may produce dihydroxyadenine stones. Alkaptonurics produce homogenistic acid stones, and aminoglycinurics produce stones of glycine, proline, and hydroxyproline. Urolithiasis has also been noticed to occur in the setting of therapeutic drug use, with crystal of drug forming within the renal tract, and some people currently being treated with agents such as andinavir, sulfadiazine, and triamterene. Following are some of the laboratory investigations which are carried out in a patient suspected with the urolithiasis. The first one is microscopic examination of the urine, which may show red cells, bacteria, leukocyte, urinary cast, and crystals. Urinary culture is carried out to identify any infecting organism present in the urinary tract and sensitivity to determine the susceptibility of these organisms to specific antibiotics. Complete blood count is also carried out, which look for neutrophilia in case of infection, and it is also shown in the steroid stone. Renal function tests are carried out to check the degree of damage of the kidney. 24-hour urine collection to measure total daily urinary volume, magnesium, sodium, uric acid, calcium, citrate, oxalate, and phosphate is also carried out. And chemical analysis of the stones can establish their composition, which in turn can help to guide future preventive and therapeutic management.